virtual geniuses I have joining me today. Thank you, gentlemen.
Thank you for having us. Hello.
Great. Well, I'm going to actually ask Catherine or Sarah to go and stick your bios there in the chat box in case anyone is not familiar with CVS Health, United Healthcare, or Amwell. But I think most of you are, and really, I'm just so delighted that we have such a prestigious group here today to talk about virtual care and COVID, which I think has really been a turning point. I mean, this pandemic in terms of virtual care, and we have just shot up to amazing amounts of adoption in the last 12 months, and we're gonna be going much further. So I'm very excited to hear your feedback today and your perspectives, and just thank you for joining us. So what I'd love to do is just kind of dive in a little bit in terms of your organizations. We know who your organizations are, but I'd like to kind of dive a little bit more into your leadership at those organizations. And I'd love for you to think back 12 months ago when this whole thing first started, the beginning of COVID-19, and what was the moment kind of in your organization or in the environment when all of a sudden you really realized that things were going to change dramatically in terms of having to ramp up or change your resources or adapt to this. And I'd love for you each to kind of just share with us, was it a conversation you had? Was it a piece of data you saw in your organization? And take us back to that point last year. And why don't we start with Dr. Schoenberg?
Sure. Trying to remember a year ago now is an unprecedented level of effort because so much has happened. But thank you for doing this. It kind of brings memories. You know, there's so many moments, but I think that the one that kind of sticks to my mind is, I think it was somewhere at the beginning of April of last year. So this was, you know, things were evolving. And, you know, we do telehealth, so we run servers and machines and all of that kind of stuff, a lot of technology. And I remember that roughly around that time, our CIO came forward and said, listen, we're seeing this hike in traffic, which may be related to COVID or something like that, in the early days. And he said, look, we have, you know, in the budget for the year, we have an allocation to move from, I don't know, it was 15 video servers, like video chassis that we operate. We have the budget, you know, for the duration of the year to go all the way to 100. And I think it may be a good idea to execute on it now rather than wait until the end of the year. So we scratched our heads and everything else and so on, and we said, okay, let's do it. And we put the order in and we got the 100 chassis, you know, into the system. And what I remember is that on the same week, in the weekend, on Sunday, CIO calls me up and says, it's not enough. And I remember getting pale and kind of said, what do you mean it's not enough? This is the entire year worth that came in a week. And he said, it's maxed out. And everything that evolved following it, because we couldn't get it. And, you know, people were kind enough to literally send us trucks of servers from the manufacturers, from Cisco and from other places, you know, literally to our server farms to deal with the supply. But that was a moment that I remember the goosebumps.
And can I ask what you're up to now?
Oh, in terms of, I actually don't know. I have to ask our CIO, but it has grown. I think that's, you know, we made that publicly known. We in different areas and different kind of parts of the country, we had a 40 times increase in volume within weeks. Wow. 40-fold.
That's incredible. Yeah. Adam, how about you? How about CVS Health?
Yeah, so thank you for having me. This is great. Great to be on here with very distinguished individuals. Doctor, and just Adam. I think when I was a medic in the Army, they used to just introduce me as just Adam because I was around so many full-bird colonels and doctors. For me, it's twofold. One, as an organization with the front door to health, if you will, for the United States, we obviously were monitoring this, you know, very, very early on with plans and looking at strategies around this. I lived in Issaquah, Washington, which was about 15 miles from the first case of COVID in the United States, which was in the Everett, Kirkland area. So it hit home very quickly for me, and the sense of urgency as an organization was pretty high since day one. I think from a metrics perspective, what was really surprising is we saw about 600% increase in telemedicine visits right at the beginning of COVID. So we knew that there was not only a mindset shift to starting to use virtual, not just because of recommendations not to go in person or anything like that, but just folks in their mind saying, oh, I remember I have X. And seeing that the organization quickly pivoting to making sure that the barriers of entry of any type of user experience around telemedicine were quickly removed. I think that was one of the biggest sort of ahas, is really how quickly can we get people access to care without any friction whatsoever, and how do we rapidly mobilize around it? It definitely went from 0 to 60 from a virtual care perspective, in record time. We stood up a 20 or 30 person team just to deal with virtual care, and so it became a high priority very quickly.
Wow, interesting. Okay, Saurabha, Dr. Bhatnagar.
Saurabh is just fine. Thanks again for having me, and great to be on with Roy and Adam. I would say, maybe two perspectives. One is from my United Health hat, and then the other one is outside at my hat at Harvard. So in my role at Harvard, we actually do executive education in China. So I was actually scheduled to be in China March of last year. And so in December timeframe of 2019, it's hard to, as Roy was saying, it's hard to think about the years, but we were thinking about, okay, when is this trip going to happen? When are we going to set up this trip, meet with these executives, set up the whole week of education out there? And it just kept getting pushed back and back. So that's when I first started sort of thinking about, okay, how big is this really? And if it's sort of shutting down travel from our perspective to be able to go into this country and travel out of the country way back before it even started hitting the States. And we started talking about it in terms of the federal government here. It was an interesting time point. And then when it really hit home, I'd say fast forward a couple of months and we're at an executive leadership meeting for our entire government program. So both the Medicare business and the Medicaid business. And the meeting quickly went from a scheduled 30-minute meeting to a scheduled full day meeting of what is our COVID response. And the meeting, never really ended, because it kept kind of going of okay, we have another problem we have to think about the solution for. What's the next problem we have to think about the solution for? And what was initially slated, okay, we can kind of get through this idea of what is our enterprise-wide response, and especially for our members that in Medicare and Medicaid, especially Medicare, some of the most vulnerable members, in those that are 65 and older. We were thinking that through, and it quickly, everyone's calendar was very clear. Everyone's calendar had to be really focused on this one enterprise priority. And then the other thing I would state is the timelines became shorter and shorter in that first 24-hour period when we started realizing, looking at some of our data and what our members were calling us about, how do we really make this easier solution for our members when there's still a lot of unknowns? That's the other idea that I would just say, in the early days for us, and still is continuing to be challenging as we sort of evolve into the next question of vaccine deployment and answering the questions for our members, both from an operational perspective, how do we set this up? And then two, how do we set this up when there's so many unknowns and our members are looking for us for answers for many of those unknowns, similar to that they're looking for the federal government and their state agencies as well.
Mm-hmm. It's interesting. We've heard that a lot this week. Dr. Turney, the CEO of Marshfield Clinic, told us yesterday that her priorities are now all COVID priorities. There's nothing else on the table right now. So one of the things I was really curious to ask you about is everybody's really struggling with how to scale up to this and address this. And there's certainly a lack of resources across the board. So when you started to shift resources and adapt, what's the most difficult in terms of resources for you? Is it the staffing? Is it the training? Is it the technology? Tell us about that, because you are large companies and we all think you have these vast amount of resources and people on staff to address these things. Let's start with you, Mr. Pellegrini.
Well, that's a great question. The good news for CVS, and I've been here about a year and a half, maybe a little bit over a year and a half. CVS, obviously, as an organization, is a health plan business. Aetna, Caremark, our PBM, and our front store, our store footprint. All three of those by themselves are typically very high capacity organizations. So what is good is they're used to being able to throttle up or down as necessary with regards to any types of even seasonal demands. Obviously, we do flu shots, one of the biggest provider of flu shots in the country. So we're used to being able to mobilize quickly around big tasks. I think I would say was an opportunity more than a challenge was how do we actually knit the consumer experience better together across the organizations. And I think that was the big opportunity was, yes, these are really big organizations that are really used to doing massive volumes of everything from a care delivery, care management, pharmacy perspective, but really, really focusing on how do we make it seamless and omni-channel for the customers. So I think what we really started rallying around was an enterprise approach to virtual care, which is the team I lead, and focusing on looking across and saying, how can we make this even more user-friendly, simpler, less friction, and then of course omni-channel. You should be able to talk to a Minute Clinic nurse practitioner via video, just like we're doing now. But if you need to be able to safely go into the store and talk to that nurse practitioner in person. And we have thousands of Minute Clinics and the ability to do that. So really, I think for us, it was less about how do we ramp up capacity, but more how do we normalize the consumer experience so that it's actually, I don't want to say delightful, but it should be easy to use and don't make me think. And I think that's what the organization really rallied around as an opportunity.
Yeah. Great. Roy, how about at Amwell?
Well, the technology, once we got all the servers in and everything else, the technology was fine and it scaled. And interestingly enough, the clinician supply for the services was actually fairly available. A lot of clinicians were also forced out of their office and everything else. So we had that, working well. The part that was definitely stressing the system that we learned a lot about ties exactly to what Adam was talking about, is actually the unfun part of support. Support is like a gray area kind of thing that you think everybody should find their way through the system and through technology without any help because it's supposed to be so simple and intuitive. The reality was that we learned about things that you only learn in high volume, things that seem like little noise in the background when you're at low volume, and then suddenly you explode and they become material. And, to give you an example, like the realities of COVID, everybody's home. If they need to use, whether you're a clinician or whether you're a patient and you're using a computer, you can't use the computer speaker and microphone because your family is around.
Right.
So everybody's using a Bluetooth headset. The magnitude of the avalanche of support issues around using Bluetooth headsets has exploded. That's just an example. There were a lot of other, support elements, but these are the kind of areas that you are humbled in thinking that things that are at the periphery of your vision are actually so critically important and become such an obstacle for people to use. And they're as important as anything else, because if you can't get the audio and video to work, you're not doing telehealth successfully. So we learned a lot of lessons. Let's just put it this way.
That's really fascinating. Saurabha.
Yeah, I would just add, I think there was a lot of those lessons around people, process, tech, operations that we learned early on. Maybe I would add on to what my colleagues have said and kind of go into where at least our mindset is shifting now. So, being a large global company and having both provider operations as well as payer operations in multiple countries, and having personnel even for our payer business in multiple countries, there's constant emergencies that you're dealing with. So I wouldn't say that the pandemic is something we've plan for, right, as a large organization. That being said, we know how to do emergency response, emergency preparedness, because we have operations globally. So for example, one of our large call centers serving our Medicare population is in the Philippines. And one of the challenges that we had to overcome successfully, especially to serve our members, is both the pandemic that was occurring at the same time and is still occurring in the Philippines, but also the hurricane that occurred at that period of time.
Right.
And so, how those two combined factors shut an entire city down and really force you to think about how to adjust your operations differently. There's a lot of reserve in the system in the way that we've built because of these, what we know in terms of the challenges and the unknowns of running a global operation. That being said, I think where at least our mind is shifting to now is really, the technology and the processes are going to continue to have new learnings for us, but the people, the reserve is at 9 months of a pandemic, and then seeing this occurring into most of 2021, really my mindset is more, how do we continue to support our staff and our resources who were great at ramping up for the first 30, 60, 90 days, 6 months, now 9 months. They're still working on really high capacity. And this really hit home for me during the holidays where, during that time, most of our employees have a good chance to kind of reset and come back into the new year. I'd say this year it was challenging because we knew there was a lot of unknowns going into 2021 that we would have to continue to mitigate and to continue to solution for. That's really where I'm thinking about in terms of as an enterprise challenge, how do we continue to support our employees during this long period of time that has gone beyond sort of this emergency response for a 30 or 60-day sprint.
Okay, great. So let's talk data for a second, because everybody on the line here is a data person. And I know you live and breathe this data, so you know what the numbers are. What were the numbers, but share for the folks on the line here. So pre-pandemic to now, what are some data points in terms of adoption that have just really blown up? And let me add one piece to that. Where do you project it's going to be in 12 months? Saurabha, I'm going to start with you.
All right, sounds good. So I mean, the data piece, I think, we've talked about this publicly, but just for the folks on the line here, in 2019, we facilitated maybe about 1 million telehealth visits across all of our plans. So Medicare, Medicaid, commercial exchanges. So all of our plans. And in 2020, it was over 20 million telehealth visits. So 20x increase across our entire plan. And what I'd also, encourage as the folks that are listening, it's not just in the population that many folks expect, those that are 20 or 30 or 40 years old. Even in our Medicare space, we saw a 40% of our members. So in 2019, only about 0.1% of our Medicare members use telehealth services. And at United Healthcare, we serve 1 in 5 Medicare members in the US. In 2020, 40% of our Medicare members. So from 0.1%, which is, I have to keep saying the point in front of it, it's less than 0, or it's less than 1, to 40% used it. And at least the trend that we're seeing as we talk to our membership and how they want to continue to use those services, since many of them have been delighted by those services, right? And we've had many strong partners in this area, Amwell included. Many of our members have been very much delighted by these services, whether they're visiting their local provider via telehealth or whether they're visiting one of our national providers. And so what we're continuing to work on is how do we make that care and more seamless, and really spending a lot of time in 2021 thinking about how do we make that journey, whether it's an in-office journey, which looks different in 2020 than it did in January, February of 2019, or a telehealth journey. How do we continue to make both of those journeys seamless, and really continue to support our members who are going to be looking for telehealth and virtual care services and even at-home services in the future.
Do you think there's going to be a dip, say, in 2022, or do you think this is going to just kind of stay at this level?
So I'm a telehealth practitioner myself, so I'm biased. I think there is I'll just caveat it with that. I think it's not going to be that peak that we saw in April and May, and probably not those high numbers that we've seen now. That being said, there are certain areas that are going to likely sustain fairly close to that peak. So behavioral health, telemental health, those are areas that lend itself very well to telehealth services. Our members have really found a lot of utility as they've shifted, and their providers have shifted from having more telehealth options available. So I'd say it depends on the type of clinic need and the type of member need. But there are some areas that we are seeing and are likely going to see that our members seek those services via telehealth at near equivalent levels, probably not at peak COVID levels when all the entire physical in-person system was shut down, but near some of those levels. And then there's other areas that are likely going to shift back to in-person care, pediatrics for annual vaccinations, or through 2-month, 3-month, 1-year vaccinations. Some of those just lend itself better to an in-person visit.
Wow. Roy, how about Amwell? Give us some data points.
Yeah, so first of all, I'll just echo the numbers, that were just mentioned, and we're kind of a little bit, connected in some ways also. So it's fairly, fairly equivalent. The one other number that I would want to add to this is that we typically think about the earthquake of COVID from a consumer standpoint. How many people were using it? How many, visits were taking place, and so on. What we tend to not look at is in my mind, the bigger revolution, which was the provider adoption of telehealth. And, while we saw, the 20x that was just mentioned and the 30x, depending on which side of the country or, which platform,
right,
the number of clinicians that signed up for telehealth was orders of magnitude higher in its growth than the number of consumers that did that. Now, the reason for that, and not absolute numbers, but the rate of growth. The reason for that was that while consumers were, stuck at home and concerned and afraid and couldn't go anywhere, and all of the places for them to go were places you don't want to be found in, like a waiting room or an ER, at the peak of COVID. So they had to use telehealth to get in front of clinicians. The reality is that most of the clinicians that work in health systems, large and small, those health systems realized that the vast majority of patient encounters that pay the bills and keep the lights on are gone. I mean, for a long period of time, they were doing only COVID or only emergency surgeries, and that's it. All the outpatient clinics are gone. All of those kind of regular follow-ups are gone. Claims cannot be submitted, and the result of that was an existential threat on the well-being of those organizations. So the policy has changed overnight by these organizations saying, we're going to, all of us, transition into telehealth in order to A, restore our existential, capacity, and B, do the right thing for the communities that we serve. So this was not discretionary. This was a premeditated transition in policy, and that was incredible. Now, to the point that Saurabha just talked about in terms of, and the question you asked about the peak, I don't think that anybody, denies the fact that the urgent care peak, was there, but as alternatives opened up, there's retail clinics now, there's outpatient clinics, things are coming back online, there are other alternatives for consumers. So the urgent care peak is going down and probably will remain there, will not come back to that level of utilization. But the biggest difference is that the wave of the use of telehealth by clinicians with their own patients, what we observe, this thing has a life of its own. It's unrelenting, and it is growing at an incredibly rapid pace. And frankly, its rate of growth is increasing because maybe word of mouth, clinicians are socializing with other clinicians that delivering healthcare through technology is kosher. These are changes that are going to affect us in years to come, way more than the panic months of urgent care during April, May last year.
Mm-hmm. Mm-hmm. Oh. Adam.
Yeah, so similar experiences. By Q3, we, between our Minute Clinics, providers, and our Aetna network, it was around 13 million just by Q3 during the pandemic. So it was a big number, and that doesn't include sort of the pharmacist interactions with regards to telephonic consultations and those kind of things that we do as well, or care managers, honestly, that are in our Caremark business or in our Aetna business, that we're actually doing a lot of work interacting with patients, either using secure messaging or other types of asynchronous telemedicine type needs. So it was a very, very big high influx. Clearly, pre-COVID, a fraction of that. We anticipate, and analysts actually predict, that there will probably say like a normalization around to about 20 or 30% above what previous utilization was. But to what Roy said and what I truly believe, I think we'll also start unlocking new use cases that consumers are just going to expect. Like in the travel industry and all the other industries out there, you can have secure interactions, asynchronous interactions, and then talk to someone by exception, using exception management as a protocol really for delivering virtual care. And I think as we start rolling out more and more things like our diabetes program we just rolled out and others, we're going to start looking at beyond the urgent care episodic needs. What are the longitudinal opportunities around delivering care longer term using virtual? And I think it's quite clear that as an omnichannel company, we have to think the fact that we're going to be able to, we need to deliver seamless care both online, post-COVID, but then you should have a seamless interaction at the 9,000 stores that we have, or the health hubs that we have, or the minute clinics that we have. So really, I think when we think about post-COVID, it's going to be more about, less about how much of a drop there was in urgent video conversations or video visits and asynchronous visits, and more about a normalization of really an omni-channel or hybrid care model that can go online, offline, back offline in a seamless way for the consumer.
I want to pick up on something you just said there, Adam, about asynchronous care, because a lot of these discussions around virtual care have really centered around the video experience. So the patient talking to the doctor live. And one of the things we have seen are these asynchronous interactions. So this would be for our audience here, emailing or texting a doctor and doing communication through a portal, not live real time, but, and we know that pre-COVID, this was not something that was done routinely for most clinicians. So how have you seen that kind of expand during this time frame? We heard often about, it's a regulatory issue. I'm not allowed to do it, or I don't have the right, technology to do it. So how have you seen this kind of change?
I think it's really, first of all, the definition of really what is asynchronous telemedicine, right? I think that's what needs to be normalized across the industry. And I think we're actually, there's a lot of governing bodies trying to work on that today. Is it an email? Is it a phone call and you leave a voicemail? Or is it a clinical protocol driven secure interaction between a patient and a provider that really, it has a little bit more structure to it. And so I think that's going to be the real key, is what is the definition and what are the specific use cases? Because clearly there are use cases that that type of modality is appropriate for, and there's use cases that it's absolutely not appropriate for. And I think that's what we're all sort of now post-COVID, we're going to be tasked with as an industry of coming up with what that is. In my mind, there are some things, I will say that I have used asynchronous telemedicine myself personally for a sinus infection, it has a clinical protocol that a provider would ask me, and if I answer the questions appropriately and then it's reviewed by a provider, then I end up having taking care of that. So I think it's going to come down to definitions, and then those definitions will really help in a way, I think, show the opportunity. But in my mind, it still goes back to every single major industry. When I call up and get a plane ticket, I don't actually call up and get a plane ticket anymore, right? I don't call Alaska Airlines and say, hey, I want to go to Hawaii next month. Can you help me get a ticket? I book my ticket. And then if I messed up, that's when I actually need to call somebody and actually have a human interaction. Because, so it really is, it comes back down to how do we leverage technology in a way that has the clinical efficacy behind it, that has protocols, that has a definition, but also leverages it so that we can use that exception management capability to deliver more care to more patients, with better clinical quality and a fraction of the price.
So Saurabha, I'm going to pick on you for a moment here as a payer. So we have heard a lot of complaints in the past that, these things are not reimbursed. So clinicians aren't going to do them. So a health plan won't pay for you to email a doctor or for a doctor to email a patient so talk a little bit about, has this changed? Is this still a reimbursement issue? Speak to this a little.
Yeah, so, I would say it's a combination of where policy is and where policy meets technology and workflow. So, and it's as with anything workflow, it's a bit of a chicken and egg where policy and payment, does that come first, or does the workflow both from a provider perspective as well as from a patient or member perspective, is it easy and simple to do? And I think, both of those things have to be solved for this to really have traction go forward. And let me speak to the provider piece and the workflow piece just a minute, just to explain a bit of what I mean. So that some of the things that you describe, whether it's email, whether it's texting, some providers have been doing it for a long period of time, right? And they just build it into how they do work. Now, are they getting reimbursed for it? That's a different question, but they just build it into how they're taking care of patients, how they're running their clinical practice. Other providers, it's not built into their workflow, and they're not going to build it into their workflow until the reimbursement piece catches up. But I think the ideal state from a member's perspective or a patient's perspective and from a provider's perspective is a little bit of what even Adam, I think, spoke to earlier, this omni-channel approach. As we're getting to be more consumer-centric and expecting this omni-channel approach from other arenas outside of healthcare. Adam gave a great example of going to Hawaii. It's going to be the same in healthcare. How do we think about this more seamless experience, both from a provider as well as patient/member perspective, in terms of what does that flow look like and how do I get access? And to me, at the end of the day, this is a new channel of approach to be able to connect with your provider or connect with a provider group. It is the core problem that we're trying to solve is how do we get more members access to healthcare services in easier to use fashion so that they're more likely to use them to stay healthy.
The one thing I would add to that is, a lot of these things aren't new. I think they're things that now I think we as an industry or as consumers have caught up with. But if I remember back, I was at Microsoft Health Vault during H1N1. And what did we, and Roy was with me, what did we do back then for H1N1? We created a clinical form with Emory that actually identified whether or not you had H1N1. And if you did, then it would trigger a delivery of Tamiflu to your house. That's asynchronous telemedicine. We just called it a form, a clinical form that then had a doctor review it and then ship something to someone's house. That was circa, 2009. So some of this stuff, I think we have to learn our lesson from this, though, and say, how do we make sure this isn't just this happens and then we don't learn from the past? I literally remember creating a Microsoft Research Center for H1N1 so consumers can go and get, templates and all this other stuff. And I thought to myself, why couldn't we just have, carried on with that and made it so that we don't have to replicate these things in the future? So I think that's going to be the real lesson learned is we shouldn't wait for another pandemic. We shouldn't wait for another sense of urgency. We need to use this as a moment, a learning moment in history and in this industry so that the next pandemic comes around, the regulations, the workflows, the best practices, the reimbursement models, all that stuff's baked. And we don't have to rapidly try to throw everything together in HTML web pages and hyperlinks and stuff that we've done for decades.
So first of all, Adam, thank you for reminding us how old we are. I remember the stage of things that took place millions of years ago. But I just want to add one dimension to it. We talked about synchronous versus asynchronous, and of course the the question we typically ask is reimbursement, because we remember the fight between video and phone. I mean, can you get charged for phone or not? But you have to have the gold standard as video and so on. There's a much bigger thing that's waiting around the corner. That's not about reimbursement for text message or secure message or something like that, but rather that the interaction between the clinician and the patient is going to gradually also be facilitated by in-betweens like AI. And we forget about the fact that longitudinal ownership of the well-being of the patient is going inevitably to be a dance between clinician interactions of different skills, interactions that are going to happen asynchronously when they're not right in front of another during that time, and interactions that are going to be automated on behalf of the clinician, for example, to gather information on a daily basis about the patient to identify whether they're going the wrong way, deteriorating, not taking their meds or whatever it is, all the way to sensors and passive, biometric devices that capture that data and bring it up in front of clinicians who need to spend time to look at the data. And then comes again the question, are they going to get paid for looking at the data that may indicate that the patient is okay? Yeah. Right? We pay for disease. We don't pay for, surveillance.
Yeah.
And I think it's the same principle of buying technology. You buy a new laptop, it's obsolete by the time you take it out of the box. If we're going to start chasing now the regulation about should we pay for synchronous versus asynchronous, by the time we get to some kind of resolution, and we're Switzerland, we're not saying one or the other, but by the time we get to a resolution, we would already be late. Right. Because AI is going to be what is, half the time, the interaction of the patient with healthcare will be with those kind of instruments. So if they work on behalf of the clinician, does the clinician get paid for that, for invoking it, and monitoring it and operating it? That's the world we're getting into very, very quickly, much quickly than we ever anticipated before.
But Roy, I want to follow up with you on this idea of regulations, because we hear from providers, there's a lot of fear about, we know there's a lot of waivers right now in terms of virtual care and being able to do this across state lines. There's a lot of fear about these waivers being rolled back. There still are regulatory barriers to being able to access this virtual care. We have a new administration in right now. What are your thoughts in terms of these regulatory barriers to virtual care? What are the biggest ones right now that we need to address?
Yeah, so again, taking the fifth on the reimbursement part of things, I think that the transition, the acceptance to the notion that the home is a valid point of care is going to be at the root of the domino effect that will force all of the other regulations to adapt. Because if we are, first of all, accepting the fact that valuable care can be delivered at home, it also means that we can reimagine where we want to longitudinally care for patients. They don't have to be in a skilled nursing facility or in a hospital. We can build infrastructure, technological and otherwise, that are going to allow managing that huge patient population where they want to be, which is, I want to be home. I don't want to be anywhere else with my sneakers and everything. So I think that part is going to create a very, very quick ripple effect. The place where I think that ripple effect is going to hit a wall, and we're going to see a bloodbath of partisan regulation discussions and everything else on the Hill and otherwise, is going to be the state licensure piece.
Okay.
Not reimbursement. And with state licensure, we have seen how we as a country can pull together using those kind of technologies to deliver areas in the country that are overwhelmed and deprived with services and knowledge and care that can come from places that even temporarily are better off. There is no justification anymore that the knowledge to care for a cancer patient that surfaced in North Dakota should be lesser than the knowledge that's readily available at Memorial Sloan Kettering in New York. And that's where the state licensure comes in. It's like saying the internet stops at the state line. I think we're the only industry that still happens. Yeah. And I think that's going to be the biggest regulatory battle that is ahead of us.
Saurabha, what are your thoughts on the state licensure issue? This is huge.
Yeah, so I mean, I think going back to even kind of the original question, I think I would agree with Roy that those are the two areas in my mind that we're thinking about as well. So site of service, because site of service of care, whether it's home, whether it's other locations, really opens the ability to care for members anywhere virtually. So I think, really advancing healthcare technology requires a forward-leaning position on that. So I think that has to be definitely re-examined and reevaluated immediately. And then I would say in terms of state licensure, I think that is just an area that it's complex. I think absolutely, as Roy mentioned, there's arguments on both sides as to where it should be. I think from our perspective, where at least the payer side of us, we are going to go with whatever the regulations state. That being said, I think thinking about where healthcare needs to be in 5 to 10 years from now in the United States, and how do you bring access to both underserved populations, rural populations, and populations that are outside of a certain geographic area. To me, state licensure is one of the keys to try to unlock that complex puzzle of how do you serve populations that are just outside of urban environments, and really get some of the underserved populations, especially in rural parts of America, healthcare access that they need, especially certain specialty care access, which may be difficult to access and very challenging to access within a 30-minute or an hour drive from their home.
It's going to be tough. I mean, there's a whole chunk of revenue for these state boards that would disappear. So it's a tough issue. I do want to ask, first of all, the participants here, go ahead and start sending your questions, and I'm going to get through one more question here, and then I'm going to open it up so we can hear your questions. I want you guys to help us stretch our imaginations a little bit, wow us a little bit. We want to hear about some of the neat things that your organizations are thinking of further down the pike. What are some of the projects that you're working on now that are really going to wow us and or help us think in new ways? And I know all three of your organizations are doing some really neat programs and pilots, and I'd love to just hear a little bit about them. If you could just give us kind of one little teaser. So Adam, why don't we start with CVS Health?
Sure. So besides this small thing of unifying a consumer health experience and making it incredibly simple across the three companies, last week we launched Symphony, which is a health hub in the home, HIPAA compliant hub that sits and is connected specifically for patients and caregivers and seniors. I think that's pretty exciting because it shows the power of home health at the home, and unifying an experience into something that's just verbal. I've always believed that distance from care shouldn't mean disconnected care, right? And so I think really building upon home health and how do we actually bring more services into the home in a seamless and simple way, I think that's exciting for us. But going back to the virtual care piece, really unifying, if you look across, Aetna and CVS, the retail footprint and Caremark, we have some incredibly amazing deep programs. And sometimes we just have so many. How do you actually personalize the experience for the consumer, curate what is necessary and needed, and then surface it in a way that's so incredibly simple and proactive. I think those are the type of things that we'll be working on, is really perfecting the ease of use and that consumer experience. I'm pretty excited also about our programs, looking at how do we leverage wearables and others to drive more next best actions, as we call it, so we can surface up for folks what should they do next before they need to think about it or have never thought about it. We're seeing great results from those type of programs. So really, to us, it's a big workload over the next 18 months to really create that just amazing experience. The don't make me think care is just there, I might actually use that. And one that's omni-channel in nature, so that we go into, the store footprint is pretty fantastic when it comes to, at some point, someone's going to want to go talk to someone. And in our health hubs, which have been incredibly, just if you walk into one, you're like, wow, you can see how this is the future of retail healthcare. The health hubs have an actual full-time FTE health concierge that's there to answer any question around health for any customer that walks in. That's not a charge. That's not as a service we sell. That's just part now of the hub experience. So when you start unifying some of those experiences and know full well that the patient can go directly into a health hub and talk to a care concierge who can then say, oh, actually what you should look at is this and this and this, or engage in this program. Oh, you have diabetes? We have a program over here. Those are the type of really simple, seamless experiences that we're going to be working on.
And are those health hubs, are they physical stores or?
Yeah, they are. Absolutely. So they're actually completely different kind of retail pharmacy. You walk in and it looks like a healthcare centric retail experience. Healthy foods, more categories for health products like connected devices and those type of things. And right in the middle of it is your health hub concierge. You walk straight up and they literally can navigate a patient through the entire store, through services, even educate what their health plan offers them. So, hey, did you know you already have this? It's free. We can just sign you up right here. So it really is, if you think about it, that anchor point, that human anchor point, because I don't believe everything's digital. I'm a digital health person, but I'm also, I'm not a doctor, nor do I play one on TV, but I was a medic. And I remember, actually taking care of patients. To me, the future is not losing the human connection, but the hybrid capabilities of both. And I think that's the manifestation of an omni-channel virtual care strategy that we're looking at.
Great. I can't wait to visit one. Where are they, the hubs?
I'll send you a list. There's one right near you, I'm sure.
Good. Well, let us know because we will send it out to everybody here. Okay, Roy, tell us, Amwell, something exciting.
Well, what he said, right? I fully agree with Adam on the home front. I really think that is the most transformative thing that we're going to see, where people can be surrounded with healthcare where they want to be. And I won't elaborate on this because I think Adam, communicated some of the thinking around it, and I think there's a world that's going to open up. I think the other piece that we're working on is actually the result of a humbling understanding that there is so much more that we don't know about telehealth, which is really tough because, we've been trying to do this for 15 years. We thought that we nailed it. We know what it is. We know how it works, what product we need to build. And then the last couple of years have shown us that telehealth is the scene of the crime, right? I mean, the place where digitally clinicians and patients are interacting. There is so much innovation that can be developed to make those encounters more informed, to expand the depth of clinical delivery that can happen there, to create derivative actions as a result of that interaction and so on. We mentioned AI, we mentioned sensors, we mentioned a lot of these different things. But what that translates into is that for the next generation of telehealth that we want to be known for, it has to be built differently to allow innovation of others to collaborate inside the telehealth encounters or surrounding the telehealth encounters. We're never going to be able to catch up with the innovation that the industry, with the thrust that's going on in the industry across the board, devices, technology, services, etc. So we need to think about telehealth more of as an open-ended system rather than a closed product. And I'll leave it at that, but I think that it's a step back in our understanding of how important we are. It's actually understanding that we're a cog in the wheel. But I think that the moment that happens, you no longer restrict the realization of the promise of telehealth, because it is the force of all of us rather than the force of a single technology that's becoming the rate limiting step. That has huge implications on how we build technologies going forward.
Saurabha, United?
Yeah, I would just echo. So, of course, the at-home piece is a big piece of what we're doing. So, one of our initiatives, Digital Health at Home, that I'm super excited about, especially for our Medicare members, is really a lot of what Roy and Adam have already talked about in terms of where I think healthcare broadly is going. So, we're really here to connect our members to the next step in their journey in a seamless and easy to use fashion. So, how do we leverage all of the information our members share with us? What we've done in 2019 to set up for some of this foundation is there's hundreds of data streams on member data, whether it's claims data, state data, provider data, that is coming into our systems. And so what we're really working on this year is how do we add some additional intelligence beyond some baseline intelligence. So true AI, true ML to some of that to help drive members to some of those next actions, whether it's in person, whether it's virtual, whether they call us over the phone, or whether they come to us through their myuhc.com member portal. Regardless of how they're approaching us, we want to make sure that they easily understand the products and services that are part of their benefits plan that they are fully paying for, and really unlock the full potential of that. And then another piece that I would just add on is this element of what happens outside the healthcare system. And we're really working on in terms of our strategy for digital health at home, thinking about how do we add additional data elements. We have a lot of our member data on social determinants, which, there's just some great panel discussions over this conference regarding some data points there. But how do we take some of that member knowledge that we know and really turn that into intelligence so that we can help drive those next actions to some of those members in a more targeted and local approach? Since, if you look at the stats, about 20% of healthcare occurs within the healthcare system. The rest of it is other elements outside of the healthcare system. And our charge, especially for our Medicare members, Medicaid members, is to really help unlock some of that potential there. So how do we marry those two of the data elements in the healthcare system, outside the healthcare system, and then really bring that together to help our members make those next best decisions, whether they're clinical or non-clinical, and regardless of the way they approach us.
We actually have a question in here, and Roy, I'm going to pitch this to you. Picking up on what Saurabha just said there's always concerns that virtual care service platforms sometimes have their own clinicians, and that when a patient meets that clinician, it's brand new and they're not pulling in data from other visits, et cetera. Can you address, how has Amwell addressed that issue? What are you doing to improve upon that?
Well, I think the first thing we do is we tell the truth, right?
Okay.
I mean, we're not trying to suggest that the relationship that you can have, or that if you have a PCP, for example, that getting an urgent care physician at 3 o'clock in the morning is going to be as informed as what your PCP can provide. We do, however, highlight the fact that sometimes the timeliness of care and sometimes the ability to get an answer for something that is bothering you can be the difference between taking good care of an issue and not taking good care for an issue. And the second thing that we do is that we try, and we do this, growingly over the years, we try to highlight where necessary different mechanism for creating continuity of care, to say, if this is the extent of the care that we could give you, by the way, we're only talking about the urgent care line of business. We're not talking about, using telehealth between clinicians and their own patients.
Okay.
We growingly invest in mechanisms to highlight, this is what we can help you with right now, and this is what needs to happen next. And it's not only what happened next in terms of where you should take it, but it's also, here's the information that you need to take, and here are the reasons for you to escalate if between the time our interaction with you is over and the time you see a clinician, something bad happens. Sorry, there's interruptions going on here.
That's okay. Hey, it's it's COVID times. We're all used to it. Let me go back to you for a second, Saurabha. So one of the things we've had a lot of concerns about as well, we hear from patients, is the in-person visit is much more high quality than that virtual visit. Do you guys have any data on that, or any thoughts on that? Do you have something to argue against that point? How do you respond to that?
My general response to that is it's very condition specific and need specific. And to build, I think, a little bit upon what even Roy just mentioned, if the need is urgent care and no hands-on physical exam is needed, then I think it's debatable whether it's an in-person is better versus just doing a virtual visit. However, if it's something that really requires a physical examination, I, for example, am a rehabilitation doc. So when I started doing telehealth in my practice, I had to decide what elements of my own clinical practice are translatable to virtual care. Now, there are certain elements that are not, right? I can't do a knee injection for osteoarthritis in a virtual visit. I can't do a hands-on physical examination, even, for example, a gait examination for wheelchair eligibility is somewhat limited in terms of what I could do in terms of a virtual visit. So some of those things, I think it is as telehealth, especially as we've seen this boom occur this past year because of COVID, I think what's also going to follow now is from a lot of both national medical and clinical organizations is really trying to refine a little bit more about where telehealth is very appropriate and where it's maybe less appropriate. I don't think from an academic perspective or large organization perspective, I don't think a lot of organizations historically had tackled that. There's certain organizations, of course, that have tackled that are very telehealth focused. But I'd say just thinking about how we even train clinicians, for example, whether it's nurses, NPs, PAs, social workers, physicians. You know, I, for myself, for example, didn't get telehealth training when I was in medical school. I think that's going to change. So I think with some of that, we're going to get more refined in terms of what's appropriate for virtual practice, what's more appropriate for in-person. But I think it's hard to have a general answer to that question because I think it's so problem specific and sometimes even very type of provider specific or type of care that you're providing specific.
Mm-hmm. So we've got another question here. I'm not even sure if any of you can answer this. Adam, maybe you can, I don't know, but concerns about prescribing actually through telehealth visits. Have you noticed any differences in terms of prescription habits through telehealth visits?
I really don't have anything on that, right? Yeah. You know, I haven't looked at that. You know, I think it does go back to the question though about, you know, what is telemedicine good for, quality? You know, one of the things I am pretty passionate about is in the future of telemedicine, we should have feedback loops that really connect the dots and say, you know, these outcomes were best with this modality, with these treatment protocols, with this RX. And I think one of the things that, and this has been a problem for a while. I mean, I go and harken back to Health Vault, right? We wanted to have data liquidity and remove the walls and that whole thing. And really, I think that idea was right. I think this ability in the future for us to be able to say, I went through this stream, I had this type of care, this was what was prescribed, this was the diagnosis, and guess what? I'm doing great. You know, it's that loop. You know, we have it in other industries are out there today. You know, if you go to, if you don't like an airline, you know, you have ways of voicing yourself to the rest of the world that you don't want to fly this airline, but this one's fantastic. And this one was seamless. And this one was a great journey. And I actually got there safely, right? So I think we need to really think about how are other industries tackling quality, control, protocols, those type of things, you know, because it's not unique. If you, so I, you know, I always talk about I work on cars as a hobby. You know, if I don't do something right on a car, or if a mechanic doesn't do something right and the car doesn't go, well, there's a feedback loop right there. It didn't work. You know, we should be able to do that in healthcare. We should have these feedback loops that says what works best, and it should be clinical outcomes based and the efficacy behind it to make sure that we actually can disseminate that also, so that all parts of the healthcare, you know, any healthcare organization can learn from it. Evidence-based, scientific-driven protocols. So I think that's something that has to happen. It has to happen. We need to be able to do that.
And Jen, I just want to throw it out that,
Please.
for people who haven't been tracking telehealth for a long period of time, it may sound like every doctor shows up from anywhere, they can do whatever they want and so on. This is no longer the world of telehealth at all. Clinicians are getting certified, they're secret shopping, they're peer reviewed, medication, antibiotic stewardship are analyzed and reviewed. People are getting appropriately trained and sanctioned when they go above and beyond different thresholds. NCQA certification for the manner by which physicians are operating. The world of telehealth is very different than what it was 5 or 10 years ago.
Yeah, fascinating. Well, I love your comment. For the first thing we do is tell the truth. So I love that. I think that's
It'll set you free.
yeah.